It's a pleasure to give this brief seminar regarding systemic amyloidosis and the importance of developing a broad differential diagnosis in order to diagnose this rare, potentially life-threatening, but treatable condition. Here is an unfortunate but yet typical case of cardiac amyloidosis. This is a 62-year-old gentleman who's African American who had acute decompensated heart failure. He had a remote history of severe hypertension and had an aortic dissection repair along with an aortic valve replacement in 2008. And he had several previous hospitalizations, 8 as you can see here, for worsening heart failure over a 3-year period. When he initially presented in 2015, his blood pressure was normal, and then in 2018 he was hypotensive. He initially had an ejection fraction that was preserved, albeit not normal, with an increased wall thickness, no significant aortic stenosis, and evidence of right ventricular hypertrophy in addition to his left ventricular hypertrophy. Laboratory testing was appropriately performed to assess for a monoclonal protein and the substrate for AL amyloid, and he did have an elevated lambda clone, as you can see, with a normal kappa light chain and an abnormal ratio. He had elevated cardiac biomarkers, including troponin I and NT-proBNP. At that point, he should have underwent an endomyocardial biopsy or tissue biopsy, but mistakenly he had a PYP scan that was unremarkable and did not show evidence of TTR amyloid, though he had the substrate for AL amyloid. And unfortunately, several years later, he was eventually diagnosed with light chain amyloidosis, but he passed away given his advanced phenotype. This is unfortunately not a rare occurrence, as documented by Isabel Lusada and colleagues when they interviewed patients with AL amyloid or their caregivers. 3/4 of them had to see more than 3 physicians before a diagnosis was made. And in 2/3, the diagnosis took more than 6 months to arrive at an accurate diagnosis of systemic amyloidosis. Many patients received an incorrect first diagnosis, and very few of them had the diagnosis made of cardiac AL by a cardiologist. Most often, cardiologists attributed the phenotype that they were seeing to hypertrophic cardiomyopathy or hypertensive heart disease. This is a famous study that was written by an educator named David Eddy many years ago when he described how physicians arrive at a diagnosis and the art of arriving at that diagnosis. And he submitted that it was impossible, given the complexity of the patient concerns or complaints, their signs and symptoms, and the multitude of diagnoses, to use what we call Bayes' theorem in routine diagnosis. What you needed to do was recast the problem using comparing patterns. Ideally, patients have multiple concerns, signs and symptoms that they're complaining about, and those get aggregated into a focal pivot. And from that pivot, you generate a list of causes. You subsequently then prune the list based on diagnostic testing, and you ultimately come to the final diagnosis. And Dr. Eddy purported that the key mistake in arriving at an incorrect diagnosis was failure to generate a broad enough differential diagnosis and a long enough list of causes. For example, seeing a patient who has a thick-walled heart and assuming that the cause is hypertensive heart disease, when in the example that was provided, the patient had a thick-walled heart but did not have concomitant hypertension. So one needs to create a broad enough differential diagnosis, and certainly systemic amyloidosis needs to be included often in that differential diagnostic list. What is systemic amyloidosis? It's a disorder characterized by misfolded proteins that deposit in the extracellular space, and they progressively interfere with the structure and function of the organ that they infiltrate, be it the heart, the kidneys, the nerves, the liver. While there are dozens of proteins in the body known to form amyloid fibrils in vivo, in the heart, because us cardiologists are not very bright, there are really only 2 main types of protein that cause amyloidosis: light chain amyloid, caused by a plasma cell dyscrasia, and transthyretin amyloid that's either due to a variant or mutation in TTR inherited in autosomal dominant fashion, or so-called senile or wild-type cardiac amyloidosis. This chart delineates some of the major epidemiological, biological, prognostic, and therapeutic differences between AL, variant TTR, and wild-type amyloid. AL is a disorder of middle age with equal males and females, and the precursor protein causing the disease is the monoclonal light chain. There's no known genetic cause, and the heart is involved in about 2/3, as is the kidney. Peripheral and autonomic neuropathy is less common in about 15% of patients. Patients often present with symptoms that are nonspecific, including fatigue and effort intolerance, edema. They may have laboratory findings of nephrotic syndrome or elevated NT-proBNP or troponins. And they could have neuropathic complaints or abdominal complaints related to GI involvement. The prognosis is highly dependent upon the stage, and unfortunately, patients with advanced disease when they're diagnosed don't do very well. And the treatment here is anti-plasma cell therapy. Wild-type TTR is a disorder predominantly to date of older adult males. Again, the precursor protein is TTR, and there's no known genetic cause. There's a whole host of orthopedic manifestations, including carpal tunnel syndrome, lumbar spinal stenosis, and a biceps tendon rupture that can precede the development of the clinical cardiac involvement. And again, prognosis is dependent upon stage, with stabilizers currently being the only approved therapy, though we have data now suggesting that stabilizers and silencers are effective. And then there's variant disease that is dependent upon the particular variant in TTR. There are over 130. This is inherited in autosomal dominant fashion. Some affect people of very young age, some have a later onset predominance, and there is somewhat of a male predominance. Again, prognosis is dependent upon stage, but involvement here is cardiac in most and peripheral and autonomic neuropathy. And we have both silencer and stabilizer therapy. Why do individuals miss the diagnosis specifically of cardiac amyloidosis? Well, it's thought to be rare, but it's really an underappreciated and much more common cause of heart failure with a preserved EF and low flow, low gradient aortic stenosis. As I mentioned, there are a whole host of non-specific symptoms that the clinician needs to aggregate, find a pivot, and then create a broad enough differential. And unfortunately, there's no common, I should say, pathognomonic sign or symptoms. While macroglossia, big tongue, and periorbital purpura are highly specific for AL amyloidosis, they're not seen in enough patients to be a sensitive marker of the disease, though they are specific. This disorder, amyloidosis, is a great masquerader, and if you're a prepared clinician thinking about the disease and entering into your differential, you can easily diagnose it. And there is some nihilisms in that it's thought to be untreatable, but treatments do exist and are very effective if diagnosed early. So to quote William Osler and Sherlock Holmes, the key to correct treatment of a patient is actually diagnosis, diagnosis, diagnosis. You cannot treat what you have yet to identify. And so the main message from this small, brief seminar is to include systemic amyloidosis on your differential diagnosis where appropriate, and I'm sure that will increase your ability to make the diagnosis in a timely and effective fashion. Thank you for your time and attention.